Okay. Hey, can you give us just the chief concern? And then we'll get started.
Right. So the chief complaint is bilateral lower limbs weakness for 20 years.
Bilateral lower limb weakness for 20 years. Valeria, what are you thinking?
Yeah, this is very helpful. I think we're giving the kind of a little bit of clues on the localization and also the time course. So when it comes to bilateral lower limb weakness, I mean, I think about the corticospinal tract, and even though it starts in the cortex in the brain, there are not a lot of causes of bilateral limb weakness that come from there. Only two exceptions that come to mind are a mass that is between the cortices itself, like a meningioma or something that is compressing both tracts in the medial part, or an anatomical abnormality of the anterior cerebral artery, sorry, which actually I remember this patient that I saw that came to the stroke unit, and the chief concern was bilateral limb weakness. And I was like, what is he doing here? Because I didn't think that was possible. But then that had this anatomic abnormality. And then the tracts come down to the coronary radiata, to the brainstem, and then go to the spine. And then they go out to the peripheral nervous system through the nerve roots, to the peripheral nerves, and to the muscle through the neuromuscular connection. So anything affecting any instance of this can lead to, well, bilateral weakness, but when it comes to bilateral lower limb weakness, the most common causes are from the spine and then going down to the periphery because of the distribution of the nerves. So yeah, and so I will think something affecting the spine or the roots or the nerves or the muscle or the neuromuscular junction. So that's kind of where I am.
Fantastic. Brilliant discussion, Valeria. So master class here for folks learning neurology when we think about a chief concern, this case being weakness, to try to think about what tracts are involved, and anywhere along the tract that could be affected could cause the symptom. So if it's the weakness, we want to think about the motor tracts, and Valeria led us through those from the primary motor cortex and the precentral gyrus down through the white matter of the cerebral hemisphere, so the brainstem, spinal cord. Those are the upper motor neurons, and then lower motor neurons from the anterior horn of the spinal cord through the ventral roots, nerve plexuses, nerves, neuromuscular junction, and muscle. So anywhere along there, a lesion could cause weakness. And then we use the pattern of weakness to try to figure out where we are. And so if we have bilateral leg weakness, Valeria actually began with two sort of gourmet pearls for us, right? So these are less common, actually very uncommon ways to get bilateral leg weakness. So let's put them aside for the moment. And let's come back to them in a second. But Valeria, you said most likely this would be a problem in the spine or peripheral nervous system if it's bilateral leg weakness. Why is that? Why is that the case? I agree with you. Why is that the case?
Because in the cortex, it will have to be both cortexes affected for both legs to be compromised.
Yeah, and then, right. So that's correct. Why that would be less common, and why is it more common for it to be the spine or below?
Because it's on a smaller space. So something affecting the spine or the nerves diffusely, I will imagine would have that pattern. Whereas if something was higher, would compromise the arms or the cognitive function of the person.
Perfect.
We don't have that here.
Sorry. Yeah, perfect. Right. So in the brain, right, to get bilateral brain lesions only affecting the legs, Valeria told us how we could do that. The leg areas are on the medial parts, represented in the homunculus and the medial parts of the precentral gyrus. So if you had a midline lesion, like a parasagittal meningioma, or if you had bilateral ACA strokes from the ACAs coming off a common trunk called the azygous ACA variant, both very uncommon, but worth thinking about if a patient has bilateral leg weakness and you keep looking at the spine, and you don't find anything. But then in the brainstem, to get bilateral lesions of just the leg parts without getting arm or face, no cranial nerves, that would be a stretch, right? We keep coming down the cervical spine, right? We would get arm and leg together. So we're really thinking thoracic spine or below. Because in the thoracic cord, you could get legs without arms. In the lumbar sacral cord, you could get legs without arms. Once you get out to the periphery, if the process has been going for 20 years and has only affected the legs, hard to imagine a diffuse neuropathy that's affected the legs for 20 years and never made it to the arms if it's affecting all the nerves. Maybe at the very beginning, It's length-dependent, lower extremities first, but 20 years, that would be a bit of a stretch. A muscle disease could start with proximal leg weakness, but probably after 20 years, we're going to get proximal upper extremity weakness as well. And then neuromuscular junction disease, the most common is myasthenia. We're almost always going to get the eyes at presentation. Maybe we'll learn that that's also a feature here, but we haven't heard about it yet. And then we talked about muscle out a little bit out of order. So all of these are possible, but when I think lower extremity, bilateral lower extremity weakness, I always think thoracic spine or below. And I say thoracic spine, thoracic spine or below, including lower motor neurons, neuromuscular junction muscle. But I think that spine is most likely, and I'm saying spine specifically, not spinal cord, because it could be the spinal cord itself or the cauda equina, which is in the spinal column, which is the lumbosacral nerve roots. So if I just hear bilateral leg weakness off the bat, I'm thinking this is probably spinal, I think spinal column, because I always say spinal cord and I correct myself, spinal cord or cauda equina, most likely, although an early peripheral process would be possible. And then the most gourmet, unlikely, but it's morning report, you never know, could be a midline brain lesion. Okay, so with those localizations in mind that you gave us, Valeria, spine being most likely, peripheral, maybe, but 20 years just leg would be less likely, and then brain least likely. What would you do with the time course? Does that help us at all here?
Yes, I think it's very helpful. When we think about very chronic conditions, I think the first thing that comes to mind is mass lesions, like tumors growing in the spine and slowly compressing. But also infections, for example, here in Peru is very common HTLV1 in some places, and that can present very slowly, usually with only motor involvement of the legs. And yeah, I would like to know a family history in that case. So I guess those two things came to mind. I really don't think like vascular causes will be too long for this, so I really don't. And metabolic causes also maybe a little too long. Even though vitamin deficiencies, I think, take some time to develop, 20 years does sound like a lot.
Yeah, great thoughts. Yeah, so we're in the chronic, very chronic time course here, 20 years. If we're right that we're in the spine, what would be the most common, Valeria, common sort of just epidemiologically common thing that could cause chronic compression of the spinal cord or nerve roots? Was something you didn't mention, but common.
Like a disc herniation?
Yeah, just degenerative disease of the spine, right? Spondylosis, disc degeneration, that would be the most common. And here we'd have to either be thoracic or lumbosacral, and the thoracic spine is not very mobile, so lumbosacral spine problem. This is morning report, but maybe A is going to be showing us a very common diagnosis presenting in a late stage of just compression by spondylosis and degenerative arthritis. What else could be in this chronic time course? You mentioned a tumor. Would have to be a very benign tumor for 20 years, maybe some type of meningioma affecting the cord or something like that. Great thought on HTLV1. We think of infections as being acute, right? But HTLV1 is a retrovirus that very rarely can cause, is common in the Caribbean and in Japan, I believe. People can correct me if the epidemiology is more broad than that, but that's my understanding. And it's a very slow infection that causes a progressive myelopathy. It's often imaging negative, but the CSF is inflammatory. And we see a few cases of this every once in a while here in San Francisco in our veteran population who served in South and Southeast Asia and picked up the virus many, many, many years ago. My understanding is the virus itself, many more people are infected than who actually developed what's called, HTLV1 associated myelopathy, right? HAM, it used to be called tropical spastic paraparesis. So maybe a slow infection. And then another category to consider would be genetic conditions. If we're correct that we're in the spine, like hereditary spastic paraplegia, there are countless hereditary spastic paraplegias that are genetic, inherited, spastic paraplegias. Yeah. So I guess I would be thinking, I was thinking structural or genetic myelopathies. And then you made the excellent point also something like HTLV1 myelopathy. Okay, so we're thinking we're in the spine, less likely in the periphery if this is just leg, but we don't know yet. Least likely upstairs in the brain. We're thinking structural versus genetic versus maybe a slow infection. Valeria, what are you listening for on the history to try to clarify the localization and to try to clarify the differential diagnosis?
Yeah, well, at first, I would like to know if it's just the legs that are compromised, if there's another part of the body, like the face or the arms that are also compromised, because I think that will probably make us think, okay, maybe it's not the spine or not that thoracolumbar spine as we thought. And then if there's a predominance, distal versus proximal, if it was ascending or descending. Also, if there was sensory involvement as well. If weakness was the only symptom, or maybe there was systemic symptoms as well, like that could lead us to a systemic cause of myelopathy or something else. And what else? And well, of course, if this patient is coming from somewhere that they have HTLV1 or they have family history of HTLV1, sorry.
Fantastic. Yeah. On the localization side, right. We heard that the concern is leg weakness. Does the patient also have hand weakness? Then we have to revise lots of things that we said about this being thoracic cord or below, as you said. Is this pure motor or is it sensory? And how would that help you, Valeria, if there's sensory also? Would that make you think more or less of one localization or disease?
Well, I think I mean, sensory and motor together make me think more about peripheral nerves. However, I mean, this will make us think also, what if we are thinking about a myelopathy, where exactly on the spinal cord we are, right? Because we have a lot of tracks going down there and up as well. So yeah, I would like to know that, and if sensory is involved, what type of sensory, because that will make us think if there's an anterior cord problem, a posterior cord problem, both. So yeah, I think that will be helpful.
Fantastic. Yeah, sensory and motor together. Well, first, if they're sensory at all, we can take muscle off the list, right? We can take neuromuscular junction off the list. We're thinking strongly of those, but those have been floated. And then we could get sensory and motor, as you said, in the spinal cord. And then which part of sensory, is it vibration, proprioception, or is it pain, temperature, could help us localize within the spinal cord, dorsal, anterior, etc. So sensory and motor together would make us think more cord or peripheral nerves. Excellent. And then when I'm curious about whether something is spinal cord, or below, there's a particular question I like to ask on exam. Sorry, it's a little guess what I'm thinking, but particular function that's important to ask about.
Do you mean reflexes? Or well, no, that's not part of the exam.
Oh, I'm very eager to hear the reflexes, but we're not there yet.
Autonomic involvement, if there's like something with incontinence or problems with defecation.
You got it. Yeah. So bowel and bladder, because bowel and bladder involvement would be common with which localizations, but less common with which localizations.
Right. I would expect that in something affecting the spine, or well, the spine. Yeah, not the peripheral nerves.
Yeah. So if we got the spinal cord or the cauda equina, probably there will be some bowel bladder involvement. Whereas peripheral neuropathies, let alone neuromuscular junction muscle disease, shouldn't affect the bowel and bladder. Okay, so we want to learn more about whether this is truly leg only. As you said, where did it start? Proximal, distal, hands, feet. Is there upper extremity or face involvement here, or eye involvement at all? We want to know if there's sensory involvement. We want to know how this sort of progressed over time. It's been 20 years. Did it happen acutely 20 years ago? Or has it been progressive for 20 years? That would obviously change our thinking on this. And then is there bowel and bladder involvement? Okay, brilliant discussion, Valeria. We have a lot of things on our radar now, and let's see if we can hone our thinking for differential diagnosis and localization based on what you will tell us about the history. Okay, sorry to talk for so long with just your 3 words you gave us, but let's hear the history now.
Yeah, no worry. That's a great discussion. I learned a lot from just chief complaint of bilateral lower limb weakness. Okay, so history of present illness. It is a 67 years old male, right-handed person, presenting with bilateral lower limb weakness for 20 years. So he was previously well, no any medical or surgical history, and no any preceding infections before that. So he just came to the clinic after 15 years of symptom onset. So we have been seeing these patients for the last 5 years. So it was gradual onset and it's persisting, just slowly progressive in nature. There was no relapsing or remitting pattern in between. At first, he couldn't just climb up the stairs or stand up from squatting position. So it's just like proximal muscles are affected. There was no fall or tripping over, and gait is also normal. So, but he has like a little kind of muscle cramps. There was no upper limb weakness at all, like that time. And then for the last 5 years, it was gradually worsening, and that's why he seek medical attention. And he also noticed weakness there, and then also nasal voice change. And there was also bilateral drooping of the eyelids, but there was no blur vision or double vision or fluctuation or fatigability. But the hand grip is still normal. There was no shortness of breath or dysphagia, no sensory symptoms at all, and bowel and bladder okay. But he noticed muscle, facial muscle twitching on all over his face. And for us, the recent year, so there was worsening of both arms and leg weakness, and he has frequent falls, and even he got fractured toe on the left side. Also, like the hand grips is also reduced, and he couldn't walk at all. He just have to walk with assistance. And there was also dysphagia in the recent year, especially liquid. So he has to be very careful with drinking water or soup. Right. All other systemic other symptoms are all unremarkable.
Fantastic. Okay, wow, a lot of information there. Thank you, A. Valeria, do you just want to summarize what kind of the features here are that jumped out at you, and then with that summary, what you're thinking at this stage?
Yeah, so I think we have a 67-year-old male that has a slowly progressive, very chronic bilateral lower limb weakness that seems to have a proximal predisposition, which immediately makes me think, well, the classic thought about that is muscles being affected, right? And also what caught my attention was the fact that he had muscle cramps, which I think is also a point towards something affecting the muscles. However, the fact that he also has affection of the eyelids because of the drooping makes me think, could this be something affecting like bilaterally the third nerve? So something like a neuropathy, which doesn't seem, with the proximal predisposition of the weakness, doesn't seem very fitting. And the fact that he also has what seems pulvar involvement because of the dysphagia and the nasal voice also makes me think, could this be like a neuropathy affecting multiple nerves? And then you also mentioned facial muscle twitching, which I think could lead to like fasciculations, which is also another point towards like lower motor neuron disease. But then with the proximal distribution, which doesn't seem very fitting, the proximal distribution of the weakness, which doesn't seem very fitting, that definitely throws me off a little bit here. So yeah, I really don't know. I think right now we're definitely keeping ourselves on peripheral, but not so much on the spine, because of the face involvement and what seems like the bulbar involvement as well.
Fantastic. Brilliant analysis, Valeria. You're already speaking like a neurologist. So just so we can clarify for some listeners who might not be neurologists, what do you mean bulbar weakness? What does bulbar weakness mean? Can you explain that for everyone?
Yeah, I think what I mean is like the nerves, the cranial nerves innervating the throat, and the apparatus that gives us like the throat and the speaking and all of that.
Yeah, perfect. So bulbar, I think someone in the chat can fact check me and correct me. Bulbar comes from the French word for the brainstem, which is la bulbe. It might be the word for the medulla, or it might be the whole brainstem. It's like a bulb, like a light bulb. It has that shape. Although probably they came up with that word a long time ago, maybe the bulb. like, an onion bulb that you plant. Anyway, I'm not sure. Someone can fact check me. But so bulbar refers to weakness of the bulbar muscles of the larynx, pharynx. So lower cranial nerve functions, as Valeria said. Okay, great. So for me, what I see here is that there is weakness without sensory loss and without bowel and bladder. So I agree with you, Valeria. That really puts us in the periphery. Once as I was I followed right along as you did. A told us this began with proximal weakness. I was with you in the muscles. I heard it progress to the arms, still proximal. Okay, I'm still in the muscles. In the eyelids and face, can that still be muscles? I know there's other findings here that made you wonder about nerve, but let's just stick with the distribution. Eyelids and face, were you still with possibility of muscle, Valeria, or did that move you away from it?
Well, I think muscles. I'm right now studying for step 2. So, and one of the topics that has been a recurrent wrong answer for me, it's a type of myopathy that affects the face. But I'm not sure if with only drooping of the eyelids, maybe I would expect some other type of weakness in the face. So yeah, that's the only thing that comes to mind with muscle. Honestly, it's not my strong suit.
Okay, good. Let's make it your strong suit since you're studying for step 2. So myopathy, you use that term as general term for muscle disease. Myositis, people sometimes use that term generally, but that's actually the specific term for an inflammatory myopathy. But myopathy is the general term because, as we'll talk about in a moment, there are many causes of muscle disease. Not to be confused with the term you'll hear us say myelopathy, which is a spinal cord problem. So myelopathy, spinal cord, myopathy, muscle. Okay, there are so many muscle diseases, as Valeria is trying to learn from these tables probably for step 2. And it's a little bit overwhelming, so I think it's helpful to just divide them into broad categories. And I divide the muscle diseases into 4 broad categories, which is going to, I think, help us think about this case a little bit. And those categories are the inflammatory myopathies, the myositis ones. We'll talk about what they are in a moment. The toxic myopathies, so ones from drugs, medications. The genetic myopathies, of which there are countless ones we'll talk about, and then myopathies associated with systemic disease, 1, 2, 3, 4. Okay, what's in the inflammatory category? That's where you have dermatomyositis, polymyositis, inclusion body myositis, and the more recently described immune-mediated necrotizing myositis, which can be associated with statins as antibodies against anti-HMG-CoA reductase or signal recognition particle, can be from the drug, or believe it or not, some people spontaneously develop HMG-CoA reductase antibodies with no statin exposure, and this can be paraneoplastic in some cases. So those are the immune-mediated myopathies, dermatopolymyositis, inclusion body myositis, and immune-mediated necrotizing myopathy. Toxic myopathies, lots of drugs can cause myopathy. Do you know, Valeria, what's the most common medication that causes a myopathy? Probably the most common cause of myopathy we see in our adult neurology population.
Yes, statins.
Statin number 1 through 10, statins, but also steroids, tacrolimus. I saw a case recently of hydroxychloroquine myopathy. So there's lots of medicines that can cause myopathy. The genetic ones, this is where you're probably memorizing a lot of stuff for step 2. They're the muscular dystrophies, which are genetic disorders affecting structural proteins of the muscles. These are things like Duchenne, Becker, there's Emery-Dreifuss, which causes contractures, usually at the elbows. There is fascioscapulohumeral muscular dystrophy, with the face, scapula, and humerus being weak. There's limb-girdle muscular dystrophy, which there are many subtypes. There's one that I thought of in this case as A continued describing it, which is oculopharyngeal muscular dystrophy, where the patients do get ptosis and bulbar weakness along with proximal weakness. I saw a few cases of this when I was in Boston, because I think there's a founder population, again, fact check my recollection, in French Canadians, some of whom live now in Maine, and some of those patients came to Boston. I actually saw one case on the West Coast, also an oculopharyngeal muscular dystrophy. Other genetic myopathies, there are mitochondrial myopathies, and then there are metabolic myopathies from glycogen storage, purine, whatever, these super complicated ones to memorize which part of that pathway. And they're pretty uncommon in adult neurology, but they do occur. And then there's the distal myopathies, which are very rare. I only know their names because I studied them hard for the boards, thinking they would be on there, the neurology course. They were not, but I had to make a mnemonic. They are Wellander, Udd, Marksbury, Griggs, Nonaka, Miyoshi, and Lang. And those myopathies are interesting in that they start with distal weakness, particularly, I think, dorsiflexion weakness, if I'm not mistaken. And so people often think it must be some type of neuropathy because it's distal. Okay, so lots of genetic myopathies. And then myopathies associated with systemic disease, particularly endocrine disease. You can get a hypothyroid myopathy. You can get myopathies associated with Cushing syndrome because of the corticosteroid effects. And then there are myopathies associated with rheumatologic disease, which sort of overlap with the inflammatory myopathies because they are inflammatory, sometimes called overlap myositis. So inflammatory, toxic, genetic, and associated with systemic disease that can help organize our approach to myopathy. So yes, the lids could be involved in oculopharyngeal muscular dystrophy. I think there's some ptosis to myotonic dystrophy, another genetic one I didn't mention. And can be some bulbar weakness, also oculopharyngeal muscular dystrophy. So, and this is very slowly progressive. So it still keeps us in that kind of genetic category we thought of. But then you mentioned, Blair, the patient is cramping and has fasciculations. Does that fit with muscle disease for you?
Not really. I feel like fasciculations particularly are something that I think about when I think about peripheral or like lower motor neuron disease. But I feel like that's a point of that I have like to learn because I don't know exactly if having chronic muscle disease can also lead you to have some signs of lower motor neuron disease. I'm not sure. So yeah, it's definitely a knowledge gap for me.
Yeah, great. Yeah, I agree with you. Fasciculations in general, we would think of lower motor neuron dysfunction, root or nerve. I don't think you can get them fasciculations even electrophysiologically with muscle disease. Do you know, can you get fasciculations on EMG from myopathy? I don't think so, but I'm actually not sure either. Clinically, it would be atypical for sure, but none of these rules are perfect. Do you know, from your experience on EMG? Because there's some things that for EMG, right, can be either myopathy or neuropathy, and you need other clues. Fasciculations, I think, is unique to neuropathy. Am I correct? Or...
Yes, I think so.
Yeah. So again, the patient said twitching. We don't know yet what that is, Valir. Maybe they're so weak in the face that when they try to, just like if we're lifting a heavy box and we start kind of shaking a little bit, maybe we don't know yet if it's fasciculation, but my mind went there as well. I saw flyby in the chat, myasthenia gravis. Maybe people thought of that with the ptosis. Valerio, how come neither of us have mentioned myasthenia gravis here?
Well, that's a great thought, actually. I think what for me made me think that it's probably not likely what A mentioned, the fact that there was not fatigability, which will be something atypical about myasthenia gravis. And also, I don't know if 20 years of myasthenia gravis would be likely. And also the fact that A mentioned that there was not a like episodic pattern at the beginning. So yeah, that's kind of the things that I think about myasthenia. So that's probably why I think it's not so likely.
Brilliant. Yeah, so there is ptosis here, but we're not hearing about fatigability. And I agree, if this is 20 years of untreated myasthenia, and A also mentioned no respiratory dysfunction, no flares, this has been slowly progressive, that wouldn't really fit for myasthenia. We can look for fatigability on exam. We have the patient look up at the ceiling for about a minute and then see if the eyelids start coming down like curtains, the ptosis worsens, or then hold it up for a long time and then have them look back to the center and see if the ptosis has worsened. Fatigability would be seen in something like myasthenia, but you wouldn't expect fatigability in muscle disease. Okay, so a lot of signs pointing towards muscle here, chronic course pointing towards a genetic etiology. Just to say, I didn't say it specifically, but dermatomyositis, polymyositis, inclusion body myositis. Well, I should say dermatomyositis, usually more acute, subacute in presentation as inflammatory condition. Wouldn't be likely for it to be sort of slowly progressive. Inclusion body myositis sort of is a little atypical compared to the other inflammatory myositis conditions because it can be a little more indolent. It's also unique and it doesn't appear to respond to immunomodulatory treatment, but it has a unique pattern of weakness as opposed to the proximal weakness that's sort of non-specific muscle patterns in polymyositis, dermatomyositis, lots of the genetic ones. Do you know, Valeria, what inclusion body myositis, what the pattern of weakness is? You know what muscles they get affected? It's unique.
I remember mechanic hands, like so maybe the hand muscles. I don't remember exactly.
Yeah, you're saying two things, one of which is correct for this condition. Mechanics hands is actually a rash type of condition you see in dermatomyositis. Part of the skin findings that the hands get very cracked. So they look like, people would say like a mechanic's hands would look from working with their hands. But you are also correct that the hands do get weak in inclusion body myositis. It's the long finger flexors and then quadriceps, and I think dorsiflexion, and I think they can get some dysphagia. And some neuromuscular colleagues I talked to say they're not sure really anymore if polymyositis actually exists as its own condition. Because dermatomyositis, there's lots of antibodies now that they found. They've divided off anti-synthetase syndrome. There's all these antibodies now you can send for various myopathies that have various associations with interstitial lung disease, cancer, et cetera. And that this inclusion body myositis, this condition, may have been called polymyositis, may have been mistakenly diagnosed, and that true polymyositis sort of just kind of, it's inflammatory, it's proximal, it's a muscle disease, and it doesn't fit the other ones, but no one's found sort of a clear antibody yet. And some colleagues have said maybe it's not really its own disease, or if it is, it's very rare. As more antibodies are discovered, then people realize there are other conditions. But we're not hearing about, I forget, was there grip? Was there flexor weakness?
Yes, there's loss of hand grip later during these recent years.
Yeah, so very indolent in an older man with sort of what we think is muscle disease, some long finger flexure, some dysphagia. Inclusion body myositis could play into it. I don't believe they get ptosis in that condition, but maybe some of them can. Not every case fits the textbook perfectly. So yeah, I think we'll have to understand on the exam what that twitching thing is. If it's fasciculation, I agree, Blair, we're going to have to revise our muscle hypothesis, but hard to know at this stage what that is. And cramp, I'm not sure I'd be able to really distinguish muscle versus nerve just based on a concern of cramp. And again, is the patient seeing fasciculations or feeling cramping? That will be helpful. But okay, we've talked about a lot of stuff. In some, we have a very slowly progressive pure motor condition that started proximal, now has some distal, now has some face, and no sensory, no bowel and bladder. So with no sensory, makes it pretty hard to be nerve or spine. Face takes us out of the spine. No bowel or bladder takes us out of the spine. Pure motor, we're sort of muscle neuromuscular junction or something of the anterior horns specifically, and something like ALS, but 20 years of ALS just doesn't happen, right? So I think we're thinking more muscle at this stage, although having to understand what that twitching, as you said earlier, is that fasciculation or something else. Okay, is there anything worth knowing about past medical meds and family history, or should we go ahead to the physical exam?
So there was past medical history, surgical history were not any remarkable. So social history was not on any drugs, and no, he's not a smoker or like no alcohol drinking. But in family history, there's a lot going. So the parents are not related, but he has 4 siblings. And there are 2 older brothers and 2 younger brothers, all have bilateral lower limb weakness and ptosis. And his mom has 4 siblings, but all are girls, but all of their sons have bilateral lower limb weakness. But they don't see any medical advice or like don't get diagnosis, but they express like they have bilateral lower limb weakness.
Got it. Okay. So no past medical history, no drugs because of toxic myopathy. The 20 years of toxic myopathy would have been a stretch. But wow, I didn't expect to hear all of that family history. What does that tell us, Valeria?
Yeah, it's very impressive. I didn't see it coming as well. I think maybe we're more on the hereditary bucket that you mentioned on the possibility of hereditary myopathies. I don't remember from step 2 that myotonic myopathy, which is the one that I was referring to, that can affect the face, but with this like kind of myotonic part that we don't see in the HPA at least, is not a link to an X chromosome, which seems to be the pattern here because only men are affected. So when it comes to hereditary myopathies, I think about Duchenne and Becker. I think those are the twos. But I don't think they will live so long. Like 67 years old seems like a lot. And I know that these people have like a lower life expectancy. So I would like to learn if there are any others that can present this after in life.
Yeah, brilliant analysis of the genetics, right? This is happening only in male, so it sounds X-linked. There are so many genetic myopathies now. Even when I mentioned limb-girdle muscular dystrophy, there's, I don't know how many, 20, 30 or something gene subtypes. So probably one of them is X-linked, and maybe one of them can cause ptosis and these things. I don't think that oculopharyngeal is X-linked. You're right that Duchenne and Becker's, but Duchenne's is a early onset in childhood. I think Becker is still onset in childhood, but just a little less severe than Duchenne's, but those are usually childhood diseases. And unfortunately with Duchenne's, as you said, probably the patient's not going to live to 67. Okay, so from the time course from the beginning, we thought maybe something genetic. We were back with hereditary spastic paraplegia. Now we are with hereditary myopathy. And so one thing we've been wrestling with, Valeria, is from the beginning is the localization. We sort of narrowed that to probably in the periphery, nerve or muscle, and the nerve is still on the table because of is that twitching fasciculations, as you said. There's no sensory, so we're really between motor nerve and muscle. There's no fluctuation to make us think of myasthenia. Motor nerve or muscle, what are going to be the key points on the exam that are going to help you distinguish between motor nerve and muscle? What are you looking for, Valeria? Let me ask you this. If you could test one thing on the exam to make that distinction, what would you check?
I would say the reflexes to see if they are
Reflex.
there or not.
We'll always do the whole exam, but I know whenever I'm talking to these patients, I'm already thinking in my head, I wish I could just check the reflexes because it's going to tell me so much. And just for clarity, for everyone here, you know this, Valeria, but so everyone is on the same page. How would the reflexes be different in a motor nerve, peripheral motor nerve disease versus a muscle disease?
So in peripheral nerve disease, there will be diminished versus in the muscle disease when we will expect them to be there, preserved.
Yeah, that's right. So muscle disease, unless the muscle disease is so severe that the patient is so weak that the muscle is too weak to even do the reflex, to even pull on for the biceps to pull the forearm up. Otherwise, even severe muscle disease, if the patient has some strength, you should be able to get a reflex if the nerve is intact. But if this patient has weakness this severe from nerve disease, we have to presume that the reflexes will be absent. Very good. Okay.
Aaron, I have a question for you now that you mentioned this. It's a little off topic, but in patients that have like hypothyroidism, is the slow reflexes because of the nerve itself or of the myopathy that they can present with?
Oh, these like delayed relaxation reflexes, you mean, in hypothyroidism?
Yeah, exactly.
To that. You know, people send a TSH as part of a neuropathy workup, and residents who work with me know that I always say, look at the AAN guidelines for the workup for a distal symmetric sensory polyneuropathy. It's not recommended to send a TSH, just B12, A1C, and SPEP with immunofixation. But severe hypothyroidism, yeah, you can get a myopathy or a neuropathy. Why the reflexes have that unique pattern, I actually don't know. I'm not sure I've ever seen that in real life. That's a great question. Maybe it's, presumably it's not the myopathy. So it must be something with neuromuscular conduction or the nerve. I don't know. Do you know, why the reflexes are hung up in thyroid disease? No? Okay.
I still have no idea.
And then just for completeness, we don't think this is neuromuscular junction disease, but what would the reflexes be in myasthenia, Valeria?
Normal. They will be normal.
And then really interesting, I've never seen a case of Lambert-Eaton syndrome except on the boards. I've always wanted to see a case of it. I don't wish that on any patient to have it, but if they do have it, I hope I could recognize it and find the underlying cancer and treat the patient. But I'm so curious to see one physical exam finding that's been described. Do you know, Valeria, what the reflexes are in Lambert-Eaton syndrome? No reason you would need to know this, but
Yeah, also another thing that's tested in step 2, I'm afraid, but like hyper or areflexia. And you know, the fact that with activity they improve weakness. I'm not sure if the reflexes are improved with the weakness as well, but I think that, and I wanted to say something else. Oh, and I think Lambert also has proximal weakness as well. So maybe that's a point towards that too.
yeah, Lambert-Eaton does have proximal weakness. I think the eyes are affected less. Again, I've never seen a case, so this is just based on what I've read. And it can have some autonomic dysfunction too, pupillary dysfunction, dry mouth, etc., which we're not hearing about here. But yeah, it's reported they have this interesting finding that they have hyporeflexia or areflexia. And then because it's a presynaptic disorder, if you exercise the muscle, so you have them exercise their quadriceps, and then you hit the reflex again, that the reflex will come back. I don't know if there's any, I don't think there's any other condition that does that. It's a presynaptic neuromuscular junction disorder. So again, I don't hope any patient ever has that condition, but if they do, I would like to see and help that with that diagnosis with my reflex hammer. That would be a very interesting physical exam finding to see. But I've only read about it, haven't seen it. So if someone has seen it in the chat, tell us so you can tell us about it, or tell me someday if you're listening to this as a podcast that you've seen this and what it looked like and how you made the diagnosis. So I've been at this now for 10 years since I graduated residency. I still haven't seen Lambert-Eaton syndrome. Maybe I'm missing it or it's extremely rare. Okay, so Valeria wants to hear the reflexes, so do I, but we'll hear the whole exam because we need to hear the whole exam to make sense of this case. So, A, do you want to tell us what you found on the exam?
All right. So on examination, like general vital signs are all normal. Other systemic examinations are unremarkable. So on neuromuscular on neuro examinations, so cranial nerve examinations, there was mitosis. It was so this was conducted like on the first visit of like 5 years ago. So on cranial nerve examination, there was mitosis, and there was weakness of orbicularis oculi and also orbicularis oris. But there was free range of ocular movement, no blur vision or double vision, and there was no Cogan or cutting sign. There was no facial drooping, but there was facial muscle fasciculations, especially around the mouth. There was no tone atrophy or uvular deviation at the time. And on motor examination, so tone was all normal on all limbs. But for muscle power, there was 4 out of 5 on shoulder abduction and elbow flexion. But the other movements like elbow extension, wrist extension, flexion, grips are all normal 5/5 at the time. And hip flexion was 4 out of 5. And other movement, hip extension, knee flexion, knee extension, ankle dorsiflexion are all normal. And reflexes are +1 on bicep, tricep, and supinator, and absent on knee and ankle joint. And the plantars are all flexor. And the gait was normal. And for the last year, the patient was on wheelchair. And when he tried to stand up and walk around to observe the gait was waddling gait. And the muscle power were more reduced than before. So they were 4- on most of the upper limb movements, like shoulder abduction, elbow flexion, elbow extension, wrist flexion, wrist extension, and grip. And 3 out of 5 on finger extension and finger abduction. There was also obvious wasting of hand muscles. And hip flexion was also worsening. It was now 3 out of 5. And other movement, knee flexion, knee extension, ankle dorsiflexion, and toe extension were 4-. There was no sensory symptoms at all. And reflexes are now all absent, and plantars were downgoing. And for the last year, cranial nerve examinations were on like previous before, mitosis and facial musculations all around the mouth. But now there was 10 atrophy and 10 fasciculations. And for the last systemic examination, there was obvious gynecomastia.
Okay, there's a lot there. While Valeria thinks about this, you mentioned some named signs related to the ptosis. Do you want to explain those to people? You mentioned some signs related to the ptosis that were absent, but we'll give Valeria some time to think about all that information. And can you tell us what you were referring to with the signs related to the lids, how you tested those and what they mean? Do you want to tell us, you mentioned Kogan sign, and you mentioned another sign related to the lids. Do you want to explain what those are?
The Kogan sign and the cutting sign.
Yeah, can you explain what those are?
Okay, so the cutting sign is when you ask the patient to look at the ceilings for like 3 or 5 minutes, and if he has like myasthenia gravis, so both of the eyes will be like coming down like a curtain. So it's called the cutting sign.
Written sign, good. And what's the Kogan sign you mentioned? That's a very gourmet neurology sign.
All right. So Kogan sign is when you lift at one eyelids, and for a long time, if they have like myasthenia gravis, the other eyes will go. It has more obvious ptosis.
Yeah, you might be right. That is one sign you can see in myasthenia, whereas if you lift up the ptotic eyelid, because the patient's was trying to keep both eyelids up, then actually the other one will go down because you're releasing them from the work of both eyes. It's called Hering's law that there's equal stimulation to both lids. I think the Kogan lid twitch, my understanding, and I don't know if Kogan named 2 signs, you might be right, but I think the Kogan lid twitch is if the patient, you have them rest their eyes closed, so you give them some rest, then you quickly have them open their eye, it overshoots up and then comes back to the ptosis again because you let it rest so it recovered a little bit and then comes down. That's the Kogan lid twitch. Is this one called the Kogan sign also? I don't know. I don't know a name for that sign. You might be right though.
Yes, that's a Kogan lid twitch.
Yeah, great. Okay, anyway, those are signs of myasthenia gravis, which this patient, they were absent, the patient doesn't have, and we wanted to give Valeria some time to process all that information. So Valeria, do you want to summarize the current exam? I know Acer gave us the progression here, and then tell us where we would localize this problem. And then there's gynecomastia if you want to do anything with that.
Yeah, thank you, Hey, for these signs that I really didn't know about. That seems like really interesting, a really good way to show off on rounds. But yeah, this exam has left me very confused because when you first mentioned the initial examination, the fact that he had more like proximal weakness and the hands were spared, that made me think, okay, this is probably a muscle problem, as we were suspecting. But then you confirmed that indeed he had fasciculations in the mouth, and also the fact that the reflexes were diminished and then they were absent, which, as we discussed, was not something that we were expecting with muscle disease. So at this point, I'm really confused because I think that we were going on for myopathy, which for me, it's the I don't know if the pattern trumps the exam signs, honestly, or if there's something that can present with both types of things, or if maybe very, very long myopathy can also somehow, as we discussed, present with lower motor neuron signs. So yeah, I'm a little shocked by this.
Okay, yeah, so we got some clear signs here, as you said, for nerve, mostly that the reflexes are gone, and the patient still has some strength. So if they have a myopathy, if they have some strength to generate the muscle contraction needed for the reflex should be present, and it's not. That puts us in the nerve. A told us there were tongue fasciculations. You're about to take step 2. If you see tongue fasciculations, what disease would you think of?
Oh my God, I know exactly what you're talking about. Is it it has like a particular name, right? Like it has like a
You might be overthinking it. A patient who's weak and has lower motor neuron signs, maybe that patient, not A's patient, but might have some upper motor neuron signs too, and then you
oh, okay. ALS, you mean?
ALS. Yeah. Now, do patients with ALS present 20 years into their illness, usually?
No, no, they don't.
Yeah.
I
Yeah.
don't think.
ALS, the broader category is motor neuron disease. So disease affecting the motor neurons. ALS, it's the upper and lower motor neurons, so motor neurons of the CNS and PNS. But those patients sadly do not live for 20 years. I think usually average lifespan people can check is about 3 to 5 years. And I've seen cases, sadly, especially when there's bulbar weakness in ALS. We saw a case recently that the patient was sort of triaged as multiple cranial neuropathies, had no extremity weakness, but had severe dysarthria and had tongue fasciculations. And we said, oh no. And then we opened the shirt and there were fasciculations on the chest. And then the EMG was consistent with, well, first there was no mass or anything in the neck. We looked hoping to find something else. It was a young, healthy person. And then I think lived less than 2 years after that, sadly, respiratory failure. So you don't live 20 years with ALS. However, there are other motor neuron diseases that are less common than ALS. There's a pure lower motor neuron condition called progressive muscular atrophy. And then there's a pure upper motor neuron condition called primary lateral sclerosis. That's a very hard diagnosis to prove. Progressive muscular atrophy, you can show the EMG findings of pure motor nerve disease. Okay, so this sounds nerve. There's fasciculations, there's areflexia, so muscle is off the table. It's been going on for 20 years. It's hereditary, and there's gynecomastia. This is a very rare condition, Valeria. No worries if you don't know what this is, but those 3 things together, if they turn out to be related, make a package for you. I don't even know if this would be on step 2, but we have a motor neuron disease, gynecomastia, and slow progression family history X-linked. No worries if you...
The family history for sure is throwing me off, but when you mentioned that gynecomastia A, what came to mind were 2 thoughts. First, that maybe this could be like a paraneoplastic syndrome. But then what you mentioned at the beginning, this going for 20 years, like a malignancy, will be weird. And then maybe something endocrine. I know patients from step 2 that have myotonic, but then we'll be going back to muscle disease. Like they have myotonic dystrophy. They can have atrophic testicles. So I will suspect maybe something endocrine is going on there. But then again, we are what seems like not to be on the muscle bucket anymore. So yeah, I really don't know.
Yeah, great thoughts. Could there have been some endocrinopathy causing gynecomastia and neurology? But as you said, usually the endocrine disorders and they affect the nervous system. We're thinking more muscle disease, which is out of the picture. And good memory, right? Myotonic dystrophy is a systemic disease, and we should say a lot of the genetic myopathies have cardiac disease because the heart is a big muscle, right? And myotonic dystrophy, they have all kinds of other complications, including atrophic testicles, as you said. So that would be an interesting way to put this all together, but it's not a muscle disease. So as you said, it can't be. And then we're not hearing about myotonia, which you can test on exam by percussing the thenar eminence, and the thumb kind of comes up and then relaxes. We're not hearing about that here. So this is a very gourmet diagnosis if this is what A has brought to us, but there is a motor neuron disease associated with gynecomastia that is X-linked, and that is Kennedy disease, or I believe the name is spinobulbar muscular atrophy, if I'm not mistaken, something like that. I don't remember the gene, but it's on the X chromosome, and it's slowly progressive. It looks kind of like ALS, except that it's much more indolent, slowly progressive, and it has gynecomastia, and there's a family history. I don't know if it's upper and lower motor neuron together. It may spinobulbar spine. I don't know if it's just the anterior horns. I think it's just lower motor neuron because it has that muscular atrophy in the name. But I think what A is trying to teach us here with the gynecomastia and X-linked and the motor nerve presentation is that this may actually be a case of Kennedy disease. Valeria, how would we prove, well, yeah, how would we prove that diagnosis? How would we prove the localization first? What test would you get to try to prove that we're in the lower motor neurons here?
like a nerve conduction to see if it's nerve or muscle.
Yeah, perfect. So nerve conduction, EMG. And then if this is a genetic disorder, then if the resource is available, to send a genetic test, or maybe to know that family members already had that test. Okay, we're thinking this could be Kennedy disease. What did you and your colleagues think, and what did you do next?
Yeah, exactly. So we definitely order NAV EMG, NAV connection study and EMG, but we also ran some lab tests. So anti-acetylcholine receptor antibody was negative, but CK was a little higher, 928 unit per liter. Other direct function test was normal, and lung function test is also normal. Spirometry just show mild restrictions. Other chest X-ray, ECG, and echo were also normal. So nerve connection study and EMG.
Sorry, pause there 1 second. Valeria, what do you think about the elevated CK? What do you normally?
Yeah. Well, I think it got my attention because for this been going so long, I will expect if this was muscle, I would expect this to maybe not have this person not to have an elevated CK. But I do think that we can see an elevated CK as well with lower motor neuron disease. I'm not sure why, but maybe because of the atrophy of the muscle that is not been we're not going to be using it for very long. So yeah, I think this is like what may be confusing if we see it, but at the end it's not going to draw us a little away or into the muscle bucket again.
Good for you. Yeah, normally you'd associate an elevated CK with muscle disease, but everything else is pointing away from muscle disease based on the exam, right? We have fasciculations, areflexia. So yeah, the exam sometimes is smarter than the labs, right? And you're right, I don't know the exact mechanism, but you can get a slightly elevated CK in motor neuron disease. You're probably right that it's sort of from denervation and the muscle being sad, that it's not getting its normal input from the nerve and breaking down a little bit, but I don't know the exact mechanism. Okay, so great point, Valeria, that we have to integrate all the data and we shouldn't say, oh, CK's up, maybe it was muscle. No, the exam doesn't fit with muscle. So unless the patient has multiple things going on, myopathy and this motor neuron condition, but right, probably if everything else points to motor nerve, we can say it has something to do with that, and it's not really very elevated as it can be in muscle disease. Excellent, great, Valeria. Just sorry to pause you, we just wanted to make that point. Okay, now tell us about the electrophysiology.
Right. So nerve connection studies, motor nerve connection study of both median, both peroneal, both tibial, and both ulnar nerves show prolonged right median latency, low right median, both peroneal amplitudes. Conduction velocities were borderline in both peroneal and tibial nerves, F-wave latencies were normal. And sensory nerve connection study of both sural, both ulnar, and both median nerve were normal. So EMG, electromyography, EMG of left glossus, both bicep, left medial gastrocnemius, both first dorsal introsci, both tibialis anterior, and both vastus medialis show many very large and fast firing motor units with moderately to severely reduced interface pattern. Some fibrillation and positive shock waves were present at left medial gastrocnemius, right first dorsal introsci, and both tibialis late anterior. So conclusion, there is an abnormal study. There is electrophysiology evidence of widespread, very chronic denervation or partial renervation at many muscles from all four limbs and glossus muscles. So this is consistent with anterior onset disease. And they advise to do so this is very chronic, slowly progressive, pure motor involvement, and ECFMG confirmed chronic anterior onset. So they diagnosed with Kennedy disease and advised to do genetic testing. And the genetic testings comes out We do analysis of CAG repeat expansion in the coding region of androgen receptor genes, and it comes out expansion range, and it shows 47 repeats. So the diagnosis is Kennedy's disease.
Wow. Amazing case, an amazing diagnosis by you and your colleagues. Clinically first, based on a good pedigree, family history, exam, and then the electrophysiology proving anterior horn cell disease. We won't get into the details since we're running out of time. And then the genetic testing. Now you reminded me what gene is. I knew it was the X chromosome from the history you gave us, but the androgen receptor gene. Wow, what a case. Just to conclude, Valeria, any reflections about the diagnostic journey here? And then we'll have A give us some teaching points, and then we'll wrap up.
Yeah, thank you, A, for bringing this case. I really didn't know about this diagnosis. It's the first time for me, and neuromuscular disorders are for sure my weakness, but I think this highlights how important it is to have a good history and a good examination, because this patient had a 20-year history of bilateral lower limb weakness, which I think it's a very common chief concern, but maybe if someone had done like a more precise history, taking into account the family history as well, maybe he probably could have an early diagnosis. But I mean, I guess that doesn't change the prognosis. So yeah, but I think it's a brilliant presentation. I thank you so much for bringing this case.
Yeah, and you had a fantastic discussion, Valeria, that led us through the differential diagnosis for the localization bilateral lower extremity weakness, and then an approach to categorizing the myopathies, how to distinguish between muscle and nerve findings on exam. And then you got to the final diagnosis, something in the motor nerves, which the localization is the most important. And once you know that, and you know the time course is chronic and the family history, I'm sure if you Googled genetic, motor neuron disease, X-linked, you would already get the answer. If you added gynecomastia, you could get the answer. So my mentor, who you hear me quote many times, Marty Samuels, he used to do this and say, look, Google knows the answer. And he would type in the terms that would make it come up first. And he would say, if you type in, for example, in this case, motor neuron disease, genetic, X-linked gynecomastia, you get Kennedy's disease. But if you put weakness, fasciculation, tongue, you have to know. So the neurologist has to make the localization and understand. And then as long as you got to motor neuron disease, genetic, and you Googled this, you would have found the answer, or you looked it up in a textbook. So you did the most important work. And we can't know all the diseases. We can spend our whole life studying neurology. We won't know all the diseases. But if we can localize and use the time course and the history, family history, in this case, other factors, then somebody has written about it somewhere, and then we'll know what test to send to try to get to an actual etiologic diagnosis once we found where the problem is and hypothesis of the overall category. Great. A, do you want to give us any teaching points on Kennedy disease that you learned taking care of this patient? I'm not sure I've ever seen a case of this condition. No, I don't think I have. I've read about it. So yeah, you real life, tell us what you learned, and then we'll wrap up.
Yeah, so this is only my very first case and last case I've seen. So I'm so excited to share with all of you. So it is purely motor, so no sensory symptoms at all, but it has only lower motor neuron signs. So in ALS, it is only pure motor, no sensory, but in ALS, the examinations, we can find both upper motor neuron and lower motor neuron lesions. And it all affects with forelimbs and also bulbar markers. But ALS is very rapid progressive, and it has very short lifespan than Kennedy disease. So Kennedy disease present with very progressive and slowly progressing nature. And it just shows lower motor neuron lesion signs, and it affects both limbs and bulbar markers either. But it is X-linked disease, so it has other anti-androgen features like gynecomastia or erectile dysfunctions or infertility. But for Kennedy disease, we don't have any treatment yet.
Excellent. Great teaching points. Wow, you've seen your first case. You might not see another one for a long time, but you'll know it when you do from learning from this patient. Hopefully we will know it as well. And I don't know, I mean, it's a single gene mutation, right, with a repeat. So presumably with the advent of gene therapy and gene editing techniques, maybe there will be a cure for this, which will make it all the more important that we can recognize it early when we see our first case like A did. Okay, amazing presentation, A. Thank you for bringing us this case. Rare diagnosis, but we learned a lot along the journey, even if we've never heard of this before. Now we've all heard of it. And really wonderful discussion, Blair, as we said. You got to the overall answer, which with a quick Google or up-to-date or textbook search, you would have gotten to the final answer as well with the information you were able to deduce. So very good. We'll do another one of these soon, and great to discuss neurology with you both. Have a good rest of your day.
Yeah. Thank you, Aaron. Thank you, Valerie. Thanks, everyone.
Okay. What do I do so we don't lose this beautiful discussion?
Yeah, you just stop the recording, and then when we end the meeting, it will upload to the cloud.